Are my slides visible to everyone?
Yes, Dr. Tulsi Priya.
Good evening, everyone. Before sharing about my studies, I would like to tell you that these are just budding ideas we are working on. These are few studies I'm planning to work on. So I wish to do more of literature search to decide on which is suitable in our setting later on. So the first study I'm planning to work tentatively now is it's going to be a retrospective comparative study on effect of tissue subtraction on corneal architecture and epithelial remodeling following refractive surgery in smile and LASIK operated patients for myopia. So the purpose of this study is to evaluate changes in the corneal milieu and epithelial remodeling changes using pentacam and ASOCT respectively. And also we are planning to study patient satisfaction also by recording their visual acuity, uncorrected and best corrected visual acuity outcomes after surgery, refractive surgery in patients who had smile and LASIK operated for myopia and myopic astigmatism. We are planning to use parameters like change in K values, simulated keratometry values, and central corneal thickness measurement per diopter of ablation using pentacam, and corneal epithelial thickness measurement changes using ASOCT. And also we are planning to record their visual acuities at 2 weeks, 1 month, 3 months, and 6 months follow post-operatively. This study basically is to compare the corneal remodeling changes and also to measure visual outcome and patient satisfaction differences between the refractive procedures, and thus which helps us to know the superiority of one refractive procedure over the other refractive procedure. This will be my first topic idea. And my another idea for another study would be on the IRPL, which is intense regulated pulse light therapy in treating dry eye patients. So basically this IRPL therapy is relatively new treatment. It's particularly effective in treating meibomian gland disease patients. And this IRPL therapy, it uses a polychromatic pulse light to stimulate the meibomian glands. This improves the function of the glands, and the patient will feel less uncomfortable after the treatment. So here the purpose of the study is to we wanted to see improvement in the quality of life of the patient after the treatment. Using a questionnaire. We have it in our setting called as Ocular Surface Disease Index questionnaire, which is available as forms in our clinic. So as shown here, we are trying to ask a set of questions about the troubles related to dry eye, and we'll be recording it in this OSDI form. And this study, it gives us the effectiveness of IRPL supplementation to the normal medical therapy, topical eye drops, and also over the normal isolated medical therapy without IRPL treatment for the management, especially in meibomian gland disease patients. So my third idea of doing a study is on corneal collagen cross-linking enhancements in patients who are treated with CXL for keratoconus. So I'll be showing a case example. This is actually she was a 16-year-old female. Who presented to us with keratoconus, with mild keratoconus in the right eye and a moderate keratoconus in the left eye. This is a pentacam map showing mild and moderate keratoconus, which is very clear cut here. And so we, her visual acuity was better in the right eye than in the left eye because of the difference in the keratoconus. Mild keratoconus in the right eye and left eye had a moderate keratoconus. So we went ahead and did cross-linking for her in 2013, and she was not very regular in her follow-ups. She used to visit us once every 2 yearly. And during her follow-up visits, we saw that we found a progression in the keratoconus again. Initially, when we did CXL in her right eye, we observed that there is a flattening and also improvement in the visual acuity between two visits, between 2013 and 14. And later on in the subsequent visits, the serial pentacam map showed that there is deterioration in her visual acuity, and also there is steepening of the cone. So we plan to do a repeat CXL for the patient in both eyes. Right eye was progressing more than the left eye, so we did a CXL enhancement in 2016 for the right eye, and in 2019 for the left eye. Generally, CXL is considered to be effective for patients in keratoconus at least for 6 months after the treatment, with a reduction in the keratometric Kmax values and improvement in the topography, like flattening and gain in the visual acuity. But not all eyes will respond similarly to the CXL. So it depends all upon the corneal thickness and patient's age, especially, and Kmax values, which can influence the efficacy of the procedure. Keratoconus is said to progress generally when we see a difference in the Kmax values between the subsequent visits of more than one diopter, or a decrease in the pachymetry values of more than 2% decrease in the corneal thickness, or any increase in the cylindrical power of more than one diopters in 2 years, or a manifest spherical equivalent change of at least more than 0.5 diopters. Similarly, in patients who had already CXL, the criteria which are considered that the patient is progressing even after CXL is almost the same, like deterioration in the visual acuity and decrease in the corneal thickness, and steepening of the cone in tomography. So we thought this would be a good topic to study upon. So this is my third topic of choice, and my fourth topic is on assessment of the clinical outcomes after application of a Forcedis software in topo-guided laser refractive surgeries. Topo-guided refractive surgeries are popularly known as Contura, and Forcedis software is an advanced analytical software which is basically designed to it helps to assist with the calculations of the Contura treatment, which is done in irregular corneas. This software was developed by Mark Lebnoff in USA, and we actually started applying in our setting since a year. And also we wanted to the idea of choosing the study is to compare our visual outcomes with studies done similarly on the Forcedis software. Uh, this study is one among them, done by Philip et al. In 2020, and we wanted to study parameters like uncorrected visual acuity and best corrected visual acuity, and magnitude of refractive cylinder after refractive surgery applying Forcedis software, and changes from preoperative visual acuity when compared to other studies. So these are my 4 ideas of working on. These are my 4 projects which I would like to work upon. Thank you.
Thanks, Dr. Tulsi. So the first one, let's go back to your first one, and you can keep sharing the slides. So first one seems to be a very good study, that because we can actually, we have, OCT for epithelium thickness mapping, although lots of studies have been done, but you'll have to look in the literature and find out if there is any study which has, compared two things. One is the amount of change in the epithelium thickness. So you have basically, you're speaking about corneal architecture and epithelial remodeling. I think if we limit ourselves to remodeling, that will be a very good thing to compare. First of all, to kind of quantify that how much epithelial remodeling happens per diopter of ablation, for both SMILE and LASIK, they should be pretty similar, but they may behave differently in the first few months of post-operative period, and that can explain the visual outcomes for patients in the early days from the surgery. And the second thing we can do is like we could, use other parameters, for example, optical zones that we used, because in SMILE we are actually, making a change only in a 6 or 6.5 millimeter zone, whereas in LASIK we are actually going up to 9 millimeters optical zone. So that may be another variable to see, and also to compare whether over a long period, for example, patient in the early post-op period, and we have patients who are coming for follow-ups even after 3 months, and we do baseline OCT maps for every patient for the last 3-4 years. So even patients who are coming into us after 3 or 4 years post LASIK or SMILE, we could actually gather that data, and it would tell us about long term how they do, and that would also be comparable to our refractive result. For example, if we did a correction of -6, and if now patient is showing a residual of maybe 0.5 or something, and whether the epithelium accounts for it, that would be it can be then made useful to understand patients who may show small changes or progression of PAR in the long term, if their epithelium is changing rather than the axial length, because sometimes it's the axial length of the patient which increases, and other times we can't explain it by the axial length, then it may be explained by the corneal remodeling. So I think first you'll have to just look for a couple of studies which have dealt with this for both LASIK and SMILE, and then we can decide the parameters. Dr. Ruchika, what's your thought?
Yes, sir, I agree. I mean, I think this can be a good, because we have a large volume, and like we've been doing the epithelial maps for most of our patients now over the last, I think, 1.5 years or something. So I think she would have a good volume of patients for this, and I'm sure we can come out with some possible difference or something out of it.
And also, sir, another idea is to do a corneal densitometry study, which would become a prospective one actually. Dr.
Right.
Ruth also suggested on this, like
So how would you do the corneal densitometry on which of our devices?
in Pentacam.
Pentacam has, of course, and then also yes, I agree. So that may be a good thought. And, how would what implications would that have?
So because that's the main, SMILE being whatever, the claim of SMILE being biomechanically better than LASIK. So I think we would possibly see a difference in that only, especially the small pool of patients where we've done one eye, maybe LASIK, and the other eye SMILE. We can actually compare if there is a difference.
Right. I think that's a good idea too. Except that, such patients are just 3 or 4 that we have, where we've done one eye LASIK and one eye SMILE. Maybe 5-6 patients at the most. I can't remember more than these. But we do have, and we may have more
Or
down the line.
possibly, sir, even if it's not one eye each, between the two groups of patients for similar refractive error correction.
Okay.
Like
Matched.
matched for refractive error, we can see the difference in the densitometry.
I agree. I think, another variable which could be added for the, in the previous study that we were planning is IOP. Like how much is the, for example, if we do NCT, so how much did the NCT change per diopter of this thing? And did epithelium remodeling have any difference to play? And, also the total pachymetry change, because epithelium remodeling is actually modifying the total pachymetry also. So even that change per diopter may be a good thing to study, is it?
Right, sir.
Because that would help us understand where patients, who show refractive surprises following refractive surgery, whether their change in corneal thickness per diopter for a particular optical zone was, like what's the skew? For example, those who are showing maybe a hyperopic surprise, or those who are showing a myopic residual error, then what may be the reason? It could be easily identifiable by OCT pachymetry and epithelium remodeling, epithelium thickness changes, because suppose there is a epithelial hyperplasia more than what was required, more than what was expected, that could explain a regression. And if there was, for example, a thinner epithelium than what was expected, and that may show a hyperopic surprise initially. So these things can be helpful, I think. We can add even IOP to this, or even full pachymetry comparisons, right?
Right,
So
sir.
I think, but only thing I think is, let's first have a couple of studies. Dr. Tulsi, next week when we meet for this thing, please try to find out studies which can be used, which can help us to form a kind of a protocol for us to follow. So just look for a few studies on this. Okay.
Sure, sir.
So what about the second one? That's on the IPL. So
Yeah.
maybe Dr. Ruchika can tell us what we can do with that.
So, sir, we've like not too many, but we have noted a difference in, and the few patients that we've done have actually, given a positive feedback regarding the improvement in symptoms and everything. So I thought if we start documenting that and doing a scoring, we will have a more objective analysis of, in what all ways these patients are improving. And since we are also doing a ocular surface analysis for these patients, so we have two objective parameters to compare.
Right.
And I think hopefully over some more time we'll have more patients. So this
Do
can
you
be
think
a
we
process.
should, have we done any localized like unilateral treatments also, or we've done mostly bilateral?
So bilateral, because most of the till now we've not had any patient who's had a unilateral issue, and then
For the sake of the study, do you think that we could, offer a free treatment to the patients and do it unilateral to also let the patients compare for themselves whether one eye which was treated was much better than the other one or not?
we could, sir, we could do that. I mean, only thing is later on, if that patient, we don't know how long we have this machine with us, and
True.
then if they come back and demand the second eye to be done as well, I don't know if we have that.
Right. I understand. No, that will be a problem. In fact, I was going to say this only, that, if we are going to if you are finding that there's a significant, so are patients noticing an improvement after the first sitting itself or after the second or the
No,
third
sir,
sitting?
not the first really, but after the second, they do come back and say that we want to complete the treatment. We want the third sitting, because they start feeling that improvement after the second.
Wonderful.
Not so much after the
So,
first, because
in that sense, I have a feeling that we should not allow single treatment options to the patient, like the packages that we make. We should always have the, 3 treatment packages. Otherwise, what may happen is they may get dissatisfied after the first one and not opt for the second or the third.
sir,
But if
actually,
they
during the counseling itself, I make sure that I tell them that you have to take a minimum of 2 sittings to, feel any improvement at all. I
right.
don't,
And what's the gap between the 2 sittings?
15 days, 2 weeks.
You know what I think? Maybe what we could do is we could keep a price for 2 sittings only, not for 1 sitting. Okay. And we can tell them that minimum 2 sittings are necessary and the third one is optional. If you notice the improvement, we'll do the third one also, and you can charge 4,000 for the third one. Like if we keep 4,000 per sitting, and we can have like an initial package of 8,000 for both sittings to be covered in 15 days. And most patients, if they start noticing an improvement by the second sitting, and then they will obviously come back for the third one and will not mind paying for it. What do you think?
Yes, sir, we could do that as well.
And if you're noticing a significant benefit from this treatment in a patient, then it's worth investing in this machine also. Then we'll start thinking of retaining the machine as well. Right?
Yes, sir, but I just feel that we should have at least few more patients, because I think we possibly completed 3 sittings in about maybe 6 or 7 patients, which is still not a very big number. We
Right.
should at
All the
least
same, Tulsi, you can start with your study on these, at least those patients that we've already done, the 6 or 7 that we've already done. Let's do
Yes.
the OSI on those patients and see. That will help us also understand whether, even if we don't end up publishing it, at least we'll know whether we are, looking to buy this machine or not, right?
Yeah, I'll do it when they come for the follow-ups.
Absolutely. So quickly, let's go on to the third one. In fact, you can look at a study for this also. Like, for the next meeting, you can pick up a study which is a possible, like something which you might want to use as a baseline for your study, like similar on the same lines that, you would like to do your study as well. Right? Okay. So
Third is on
CX,
CXC.
yeah. So Dr. Ruchika, what's your thought about this one? Is it doable? Also in this patient, just stay on this graph. Somehow this second map doesn't look like it's from this patient.
I was about to say the same thing.
Yeah, so this one doesn't, it looks out of place. And, it looks like it's too much of a healthy cornea. So I'm sure that there is a mistake here. So we'll have to look back. Sometimes, the import of the data can play tricks, and this may not be from this patient, but we'll have to look back. And but otherwise, on this topic, what do you think? Should we do, like, I'm sure we have a huge database of cross-linked patients, but should we do enhancement patients, or should we do ectasia patients whom we treated and how our results were on post-CXL? But I think if we, studies may not be many on patients who got a retreatment, so that may be one area of patient. And we do have at least 10 odd patients where we have enhanced them, and we have long-term data like 10 years or more. So I think that will be the best one to publish, because very few centers would have data with properly documented data of such patients who have been enhanced and then have responded well with the so if we could make a case series of 8 or 10 patients, or even 5 or 6 patients, it would be really nice.
We have already got data of 7 patients.
Right. So let's sit down and prepare these 7 and publish them as a case series of patients who came back to us with a progression, and then how they typically behaved and what may be the risk factors and what may be the common risk factors amongst them, and how they behave post second cross-linking, and did it last, and endothelium, all these things I think would be worthwhile. What do you think, Dr. Ruchika?
Yes, sir, definitely. I think we also have a series of patients who have spontaneously regressed just by avoiding eye rubbing.
Absolutely, we do, and we
Yes.
should publish about those as well, because again they are documented on Pentacam.
Yes, sir. We have a good subset of patients where we've cross-linked one eye and the other eye we've kept under observation, and that has actually spontaneously flattened
So I
out.
think let's start taking an inventory of these patients quickly, and we should publish these. Both are very good publications that we can do.
Yes, sir.
I think, Dr. Ruchika, this will have to guide, but the IPL and this one you'll have to guide, and the other ones I'll guide, the Smile and LASIK one.
Yes,
And
sir. Yes.
it'll be very useful. So, okay, so this is the parameters for progression. Perfect. So, and what's the last one, Dr. Tulsi?
Last is on the Forceris software.
So here, Dr. Ruchika, what do you think? Like, what should we study? Because see, I was discussing with Dr. Tulsi today morning. We don't have a comparative possibility with the. See, there are problem is that because we do a lot of Smile, so we don't end up doing Contura on patients who are likely to have great results with Contura on eyes with which have very like minimal astigmatism or something. So we will have limited number of Contura patients. But most of our patients are those who have significant astigmatism or corneal aberrations. So do you think that, and also we could, either we could compare our treatments from the last 1 year where we have used Forcities for the Contura planning versus those which we were doing before without any Forcities. So that could be one area, and we could look at that as one possible study. Or second possibility is that we compare our Contura outcomes with Forcities for with previously documented studies which have reported their kind of their own success rates with the results like visual acuity and correction of astigmatism and all those things. So we should again look for a couple of studies, and maybe we can even email Mark Lovinov for a study design on how we can report our Contura results using Forcities, because he's already doing studies at a couple of places, and he may be interested if we provide our data as well and publish it.
Right, sir. Right.
So maybe I'll mail him to ask if he can tell us that what are the other studies, ongoing studies, what they are comparing and how they are, working. I'll write a mail to him. In the meantime, Dr. Tulsi, you can look up studies on, basically don't look just for Forcities, just look for Contura results, either comparative analysis or by itself, Contura results in some studies for, topo-guided treatments on virgin eyes, right?
Okay, sir.
Then we can move forward on this. So I think all 4 are doable, and let's work on these. Anything else from our other colleagues, if they have any thoughts on these 3-4 things that we are thinking of? And maybe you can stop sharing the slides now. Dr. Amrita, you have any thoughts? Dr. Saurabh, anybody else?
I think, sir, the IRPL thing is good. Actually, that is what I think me and Dr. Ruchika were also thinking of doing before. So that is one thing that we should actually document and see how useful the machine is getting us the results with all the patients that we've been treating with.
Right. Perfect. Okay. So I think we can move on to the retina side, Saurabh, unless you have something. Anybody has any thoughts? I mean, even though it may not be a subject, if you think that anything looked interesting and you have any suggestions for us, it'll be nice. Dr.
No.
Shweta, no?
No, but I think Dr. Amrita had some update about her present. I think we can have
Okay.
that, and
Sure.
then we
Let's do
can
that
go to
right away.
retina. Yeah.
Absolutely. Perfect.
Yes, sir. So I just collected a couple of photographs as we were thinking about the pre-op and the post-op comparisons. So I just wanted to show the slides to it so that at least we have a little idea which are the photographs that we would like to follow up the patient with.
Sure. Let's see those.
Are my slides visible?
Yes.
I think. Yeah, so I think there were two main concerns that we had discussed about in the last meeting. One of them were the comparison of the photos, and another was if we can actually document some iris touch. So these are two things. So the first photograph that I have is from the OCTs. So the OCTs do show the comparison between the pre-op and the post-op. So this is a pre-op photograph, and this is a post-op 4-month photograph in which there was the first documentation of the iris depigmentation that we encountered. But again, I feel the iris to phakic lens touch cannot be documented, or the distance cannot be documented into this one's in particular. So we can see the difference in both the photos here. And also this is another photo in which this is all the pre-ops we have. So we just can see by calling the patient on a post-op visit that how can we compare these photographs. So this is through the lens star that we get. And this is the lens star photo, sorry. This is the eye trace photo that I have. And I don't think the lens star photo is very clear though to actually make out the iris details in particular on it.
So, Dr. Amrita, you can actually switch off all those things, like even on this one, we can switch off all these things, overlays which are coming, and even go to the previous one.
Yes, sir.
Yeah, you can switch off the pupil, you can switch off the limbus, and even the, reticule and everything. That will make us, that'll give us a better view of the iris details. And then, you could, on one slide, you could put the right eye and the left eye in the early, before the surgery and after the surgery,
Okay, sir. I'll do that next
slide,
time.
you can remove all the overlays and
Okay.
have both eyes on the same slide.
Yes,
And show us, the pre-op, post-op at 4 months and post-op at 1 year as the patient came.
Okay, sir. I
And
think
we
by
could-
then
we
we
could
can
do that
also
both
ask the
with the-
patient to come back for a visit so that we
Right.
have the
He
post-op.
came recently, in fact, and I think we saw him just a short while back. We may have done some tests on him even on this visit. I'm not sure, but we can always call him back. He'll come.
Yes,
And
sir.
we can also do, do it on the OCT, like on the same screen, the right and the left. In fact, on one of the screens, you could actually put 4 images. Like on the upper row, you can put the right and left from the first pre-op exam, then
Yes,
the
sir.
second exam, and then the last exam. Maybe, 6 images, like
Yes, sir.
right, left, and right, left. From
Yes,
the
sir.
OCT, from the lens star, whatever we have, and from the eye trace. And
Yes,
switch
sir.
off all the overlays. Go to the next slide.
Yes,
Yeah, so
sir.
these overlays can be removed very easily. And
This
then
can be removed, sir, but in the lens star, I feel the contrast still, we weren't getting a great contrast onto it because there was a lot of imaging of the eyelashes and everything reflection that we
Right.
could see.
So this is a very poor scan actually.
Yes, sir.
Even the lid is not fully open. I'm wondering why they would have done it like this. But the quality control on the RTS is very, very important. So anyway, and also see, we may have something on the virion, okay? Because if it was a toric ICL, we must have done a virion capture also, and that will also have a color image of that eye at least, if not of
Yes,
the
sir.
other one.
Yes, sir.
And
Sure.
sometimes they might have done virion for both eyes. You never know. Just check.
Yes, sir. I'll check the virion thing, but this
Again,
is
here
the
also you
pentacle.
can remove the pupil, you can remove that green thing, and you can remove all these numbers, and it can still show you a comparison of both eyes. pre and post, you know.
Yes, sir. So I think it will be better if I could put the right and the left eyes with all the instruments in comparison. I think that is one thing that
Yes,
I'll try to.
yes, yes.
Yes, sir.
Absolutely. I think that will help us. Sure. So anyway, anything else?
No, sir, that's it. I think it was just the
Okay. So
images.
I
And
think maybe
sorry, but
next
one
week,
more
yeah.
point I wanted to mention was, so I think in the last discussion, it was also asked that how long does a anti-glaucoma prostaglandin analog takes to consider a hyperpigmentation so that the iris receptors can be sensitized for it. So the answer to that is that it can be seen as early as 1 month also. But none of the studies have in particularly pointed out on the fact that the which iris receptors in particular, because the hyperpigmentation on prostaglandin analogs also includes the hyperpigmentation of the lashes and also the skin around it. So there hasn't been any one particular pigment or receptor that has been mentioned about it, and but it can present as early as 1 month also. So I think it kind of rules out our inclination towards a prostaglandin analog being a part of this.
See, also because it is more of hyperpigmentation, and here we are having pigment dispersion.
Yes,
So
sir.
it's, you know, actually the opposite of what might have happened here. There's pigment
Yes,
loss, whereas, you know, with prostaglandin analog, we would have had hyperpigmentation, which we are not seeing here anyway, right?
Yes, sir.
But still, I mean, yeah, let's just keep that in the back of our minds that, you know, that patient was on prostaglandin analog, just in case we can find something beyond this.
Yes, sir.
Right? Okay. Okay. So let's work on this. You should immediately work on this and publish this one at least.
Yes, sir. Sure, sir.
Okay. So if you can have something ready by next week, you know, an initial draft of what you're planning to do, that will be very helpful.
Surely, sir, I'll do that.
Great. Dr. Saul?
Yes. So I think Dr. Vaibhav has his presentation. So I think Dr. Vaibhav, you can share your screen, please.
Okay, sir. Good evening, everybody. I'll be discussing all the publication projects I have been assigned. Is my screen visible?
Yes, please go ahead.
So we have 3 publication projects aligned for now. There'll be many more in the future. So first is the partial cilioretinal sparing CRO, which we are aiming to report as a case report in AJO case reports. Second would be Irvan syndrome, so idiopathic retinal vasculitis, aneurysms, and neuroretinitis, which we are thinking to keep as a photo essay. And again, we are aiming AJO case reports. Third is the systemic lupus erythematosus retinopathy, which we are aiming to publish as a case report in OII or JOII. So I'll be restricting myself only to those aspects which are publication important. So we'll start with the first case, CRO with partial cilioretinal artery sparing. So we had a patient, 76-year-old male, presented with sudden painless diminution of vision in the left eye for 1 day. The BCVA was 6.9 in the right eye and was finger counting close to face in the left eye. Patient had a RAPT defect in the left eye. Intraocular pressure was 16 mm in the right eye and 18 mm in the left eye. In the slit lamp examination showed transparent cornea, conjunctiva, deep anterior chamber without any reaction in the left eye. Fundus examination showed mild venous tortuosity and arterial narrowing with boxcar appearance. So here is the image, red-free image in the left-hand side, which shows the cilioretinal artery and all the retinal edema elsewhere. Now, basically, this part of retina temporal to the optic disc, it is not extending to the macula. When I was doing the literature search for this, I found one article, which I'll be sharing in the later slides. There, the author have defined a method to assess if the cilioretinal artery is macula perfusing or non-perfusing. What they did in that, they took a circle centered at the fovea with the radius of curvature equivalent the distance from optic disc to fovea minus 1 disc diameter. If the cilioretinal artery enters this zone, it's macula perfusing. And if it doesn't enter this zone, it's macula non-perfusing. So in our case, the cilioretinal artery is macula non-perfusing. Now, if I go back, if we see over here, there are 3 branches of cilioretinal artery. I'll just zoom it. There are 3 branches of cilioretinal artery. This is the one, this is the second, and this is the third. We did the OCT for the same patient, where we could see that there is retinal edema, there is inner retinal hyperreflectivity, and it's sparing the area which is supplied by the cilioretinal artery. So this part of the retina, which is just temporal to the optic disc, is spared. We did the OCT angiography. In the OCT angiography, there's decrease in vascularity in the superficial retinal plexus slab and in the deep retinal plexus slab, which same shows in the flow areas also. This has flow, which is just temporal to the optic disc supplied by the cilioretinal artery. This is the NFAS image of OCTA through the disc. Here we can see that there are three branches of cilioretinal artery. This is the first one, this is the second, and this is the third. Now, when I was doing literature search for this, I came across this article where they have, this is a review article in Acta Ophthalmologica, where they show the prevalence of cilioretinal arteries basically. Now they talked about cilioretinal artery. They talked about the cilioretinal artery in the nasal aspect, temporal aspect, the prevalence of it. Now, when I was going through this article, at some point of time, they told that 3-branch cilioretinal artery is very rare. It is present in 0.6 to 1.3% of people who have cilioretinal artery. The prevalence of cilioretinal artery itself is less. It is 5 to 45% in various studies. Out of those 5 to 45%, only 0.6 to 1.3% has 3-branch cilioretinal artery. And even with these 3 branches, in our case, it is not macula perfusing. That's why the vision is so low. And this is the important aspect which we are trying to put across and which we are trying to focus as a case report. Here we can see, this is the image where the patient come to us for the first time. Here we can see all the cilioretinal artery and restricted flow in the rest of the retina. It's only in the temporal aspect of the optic disc. This is the subsequent visit after 1 month, where there is recirculation has been gained and there is circulation in whole of the retina, but because of the inner retinal hyperreflectivity or ischemia of the retina, the vision doesn't improve much. On the basis of examination investigation, diagnosis of partial cilioretinal artery sparing CRAO was made. Patient was investigated with color Doppler of carotid, which showed plaque in the ICA with 50% stenosis in the same left side. So this is the first thing we are trying to put as a case report. The second,
it's quite good, and I think the patient underwent or is undergoing, I think, coronary artery stenting also.
Yes, sir. Yes, sir. Yes, sir.
And in this picture, which is quite, this I think comparison is very nice, like the acute onset of the occlusion, and now there's kind of reperfusion is there, and there. So the part which was initially showing the inner retinal hyperreflectivity in the acute
Yes.
phase is now actually showing atrophy. There's a little bit of thinning in that area.
Yes, sir. Yes.
It is thinned out. So that is nicely seen here. And so I think it's like you pointed out that the 3 cilioretinal arteries are even more rare than a single cilioretinal artery. So I think we should kind of highlight these points and focus on the uniqueness of this thing, so that it increases the publication value. So whenever we are putting together a case report, we have to kind of highlight what is unique about the case report. That's what gives it publication value.
Yes.
So, and with references, so that that will kind of help us in the the view of literature and in the discussion part.
So I am on it. I am searching for the literature more, so that we could see other studies also where they could give the incidence of multiple cilioretinal arteries.
Right. And also we can acquire these. I think Dr. Amarpal at Synergy is doing the the coronary part and the cardiac part and the carotid.
Yes,
we can get scans from him for the carotid study, Doppler.
Yes.
That also, that will give it our publication more strength.
Yes, sir. Yes, sir.
So Dr. Shweta, have anything to say? Otherwise, we can move ahead.
The only thing they might raise a question on is the fact that we didn't do an FFA at this point, but I think OCTA has, good enough documentation, and considering it was an emergency. Apart from that, I think the patient needed a nephrology clearance even for his coronary angiography. So maybe we can put that up in our defense.
Right. And these pictures will come to our rescue because, they are like dialysis
Right.
angiography. And, nowadays a lot
Right.
of operations, they are being accepted, in lieu of not having an FFA. So I think these pictures might come in handy for that.
Yes, sir.
Yes, sir. We can even propagate the idea of OCTA.
Yes, yes.
The
So,
patient like CRO, we don't know the kidney status. We cannot do a FFA
right.
in the very first visit. So
Correct.
we can propagate this idea of OCTA in these patients.
Right. Just one last question here. Like if you see the choroidal circulation, or at least whatever is made out the flow here, right in the center, just where the fovea is, there is a little bit of, like flow signal there.
Yes, sir.
So what is the explanation for that?
So we'll have to search in the literature for that. I don't know because there's no circulation beyond this area. And just beneath the fovea, we have some signals, flow signals.
So could it be an artifact?
Maybe we need to look into the other scans also. Like,
Yes, ma'am.
yes, sir.
Right, because that is what I noticed. It was quite
sir.
hearing that right under the fovea there is like a flow signal. So we must look into that, the segmentation of that whether there is any issue with the segmentation, because there is
Yes.
a small pocket of neurosensory elevation there. So whether that is causing any disturbance in the flow signal, readability of the underlying choroid.
Yes, sir.
Okay. And but at the same time, if you see the picture above, you said that in our case the cilioretinal artery was not perfusing the macula, right?
Yes, sir. Yes, sir.
So
according to the method which we have taken from that
right.
article, the author
Right.
has prescribed a method.
And in the picture on the top left, can you really show us where exactly we should expect the fovea to be in this? Can you show, I mean, like with a cursor or something, where the fovea is? Like in the right, we can make out,
Yes.
top right, make out, but in the, okay,
Yes,
so.
sir. So around here, sir.
Okay.
Because this is not a montage, so this is a montage image, and this is a single image taken through the.
Right.
So it would be somewhere here. Yes, sir.
Maybe a little to the left of that, because if you see that curved, the perfused vessel above this
Yes,
one,
sir. Yes,
above,
sir.
then the segment where the fovea is on the top right is somewhere, like after, like almost in the middle of this one straight
Yes,
segment.
sir. Yes, sir. Yes, sir.
From there, you can make out approximately the location will be a little left to what you were pointing earlier. Yeah,
Yes, sir.
somewhere.
Maybe. Yeah, yes.
Fine. So I think if anyone else has any questions, otherwise we can move on to the second one. Yeah, so I think we can go on to the second photo assay.
Okay, sir. Now the second case is a case of Irvan, which we would like to present as a photo essay. Now, this patient, a 40-year-old non-diabetic, non-hypertensive male, presented with painless progressive diminution of vision in the right eye for 2 months. The BCVA was 1/60 in the right eye and 6/9 in the left eye. Slit line examination revealed a quite anterior chamber and anterior vitreous in the right eye. Fundus examination showed inferior old vitreous hemorrhage. I'll show the image here. It showed inferior vitreous hemorrhage. Then it shows multiple macroaneurysms. One temporal to the fovea is a hyalinized macroaneurysm. Now, one at the IT arcade is an active macroaneurysm with exudation surrounding it. There's ERM at the fovea. Then there is one blocked vein at the ST arcade. And this is the autofluorescence image, which shows hypoautofluorescence at the area of exudation. at the area of macroaneurysm because of the hemorrhage, and the hyalinized macroaneurysm, just temporal to the fovea. Now we did OCT of this patient. OCT through macula shows ERM. Then there is loss of foveal contour with intraretinal fluid with intraretinal hyperreflective dot suggestive of hard exudates. When we did OCT through that hyalinized macroaneurysm, it shows a oval cavity with hyperreflective wall and with medium to low reflective lumen surrounding by hyperreflective dots. So in an active macroaneurysm, this lumen should be hyporeflective, whereas in this it is low to medium reflective, which signifies that there is hyalinization of this macroaneurysm going. Now we'll go to the fluorescein angiography. I'll directly jump to angiography and ICG. This shows the early phase. This is the fluorescein angiography, and this is the ICGA. Here we can see blocked fluorescence in the area of hemorrhage, aneurysm, with all the exudation was. Now, if you see this, when this delayed filling in this vein, the superotemporal vein, this delayed filling. And in the late phase, there is staining here, the blocked fluorescence because of the hemorrhage and exudation. One more thing, when we went to the periphery, there are some areas of NVEs and extensive CNP areas are there. Now we were searching for a diagnosis in this case. There were many differentials we came up with. Like we came up with Leber's aneurysm, we came up with adult coats, we came up with eels. But then there are few points going against all these diseases. And one diagnosis which is fitting completely into this is of IRWAN. There are very few reported cases of IRWAN in the literature. And basically, there's a staging system in IRWAN where stage 1, like in our patient, you couldn't see any neuroretinitis. And we are assuming that the patient has come in a sequelae stage, because in the active stage, it is asymptomatic. It is majorly asymptomatic. The patient doesn't feel anything. The vision doesn't go down. But it's in the sequelae stage where the vision goes down. So the patient is in the sequelae stage, so we cannot see a neuroretinitis in our case. But our case is a sequelae. We thought it to be a sequelae of IRWAN. So this is one case we like to put as a photo essay and send to maybe AGO case report.
So, at this juncture, I would like to, is Abhijat there? So Abhijat, you had a couple of queries. I want you to, share those queries, and then, we can have some discussion.
Right, sir. So my first query was regarding that, as Vaibhav said clearly, that IRWAN needs, all the features or like the major components of vasculitis, aneurysm, and neuroretinitis. And I don't see any neuroretinitis, but he clearly mentioned that it could be a sequelae. So maybe we can consider that, but still we cannot rule this. Basically, I think it's an idiopathic disease. So we need to exclude everything else. So I think we should call back the patient with all the investigations to be done first before we move on.
Right. So I think neuroretinitis, we can't see any disc hyperfluorescence here. And,
Right, sir.
classically in this, the macroaneurysms have been described to occur in the, proximity of the optic disc.
Yes, sir.
That is why there is, leakage from in the area of the disc. But, and we can't see those classical knotty appearance, like there are knots in the arteriolar circulation, and we
Yes.
can't see them here because obviously, we are supposing or proposing that this is a kind of a late stage of presentation, because patient was definitely not asymptomatic. He has a lot of exudation, vision is down to 1/60, and it's a late stage. What was
Yes,
the
sir.
My question to you here is, and I also agree with Abhijat that in the differential, besides Leber's and quotes, even hypertension has been written as a differential diagnosis. Hypertensive changes by themselves can also, give rise to similar pictures. Similar, I'm saying, not exactly the same.
Yes,
But
sir.
on the other hand, some syndromes like, like the one that you're going to present after this, like SLE and even good pastures, Wegener's, Church, Strauss, all those have been also, kind of listed in the differentials, of
Yes, sir. But
yeah, but we have to rule those out. Then only can we call it idiopathic, and then only can be, kind of. So, have we done like an ANA profile, and have we done like P ANCA, C ANCA, and ruled out, and the other connective tissue disorders which could mimic this picture,
yes, sir, we've prescribed a battery of investigation to the patient. He hasn't returned back. We are following him up.
right?
But then there were no systemic features to call it lupus or vaginous. There were no systemic features otherwise.
Right.
And one thing I would like to say is, even in lupus, it would be a bilateral thing, not a unilateral thing. It is majorly a bilateral disease. And in our patient, it is a unilateral disease.
Yeah, so when I was reading this article, so commonly IRWAN is, more commonly it is bilateral, and in
Yes,
our and but it can be unilateral, but in our case it is unilateral. Also, there's a female preponderance. In our
yes,
case, a male gentleman. So I still, kind of feel that we need to work up this case. We can't really conclude, based on the data that we have currently. I'm not saying that, that. So we need to work on this. We need to, exclude other connective tissue disorders.
yes,
We
sir.
need, because otherwise it's not fitting. I mean, the clinical picture may be of the one eye, but the epidemiological this thing is not fitting into it. It's a male and it's a unilateral case. So I still have reservations in totally accepting this as IRWAN, although we, for the time being, we were considering IRWAN, but we
Yes, sir.
need the workup and get all the result of all investigations before we, conclusively label this as IRWAN. You
Yes,
understand?
yes, sir, yes. We are trying to follow up the patient, sir. We are trying to call him.
Right.
And
And we've called, I think, advised anti-VEGF also to the patient along
yes,
with
sir.
with
Yes,
lasers.
sir.
So
Yes, sir.
hopefully,
PRP laser with anti-VEGF.
hopefully the patient follows up. So just before we move to the last, presentation by you, I just had a question. Can you tell us why and what happens, and what is the, in short, can you tell what is the pathophysiology, what has been, implicated in this IRWAN? Why does it occur?
So basically, it's a idiopathic thing, but what they say is that it affects the smooth muscles more. So that is the reason it affects arteries, and it affects arteries near the disc more than in the periphery, because smooth muscles are more in the arteries near the disc, and they tend to decrease as they go in the periphery. So basically, there they give the idea of aneurysmal dilation near the optic disc, and the multiple aneurysms. And there are some systemic associations also they have tried to give, like uh, you said, it's polyarteritis nodosa, Wegener's.
Right. So essentially, it's a fibrinoid necrosis of the smooth muscle cells. And as you said, close to the disc, the number of smooth muscle cell layers are, about 5 to 6 in the arterioles. And
Yes,
as we proceed beyond the equator, they become 1 to 2 layer thick.
yes,
So
sir.
we seen, in the papillary area. Whereas in the veins, in the venules, why they say we don't see those, changes is because near the disc, there are a few, smooth muscle cell layers in the venules as well. But when we move away from the disc, it is replaced by fibrocytes.
Yes, sir.
So those changes are not seen commonly in the venules.
Yes,
And there's an inflammation which has been, hypothesized that there's underlying inflammation of the retinal vessels, mostly a phlebitis, which is responsible
phlebitis.
for formation of these macroaneurysms.
Yes, sir.
So yeah,
Occlusive phlebitis is yes, sir.
yes. So we need to work up this case before we can, take it towards, kind of conclusive for being IRWAN. Okay. So
Yes, sir.
if there are any more questions, Dr. Shweta or anyone else, then we can, move to the third case. Please go ahead then. Yeah.
Yes. Now, the third case we are working on is SLE retinopathy, which we want to put up as a case report. We had a patient 9 male presented to us on 1st September 21 with complaint of bilateral painless gradually progressive diminution of vision, redness of eyes, fever. The girl had rash over face, chest, abdomen, back, and arms associated with painless mouth ulcer. The BCVA was 3/16 in the right eye and 6/36 parts in the left eye. Slit lamp examination revealed a quite anterior chamber and anterior vitreous face in both the eyes. This is the fundus photograph of that patient, where we can see disc hyperemia, vascular prociosity, this sheathing of vessels. There is occlusive phlebitis. There are some perivascular subretinal infiltrates. And here we can see some areas of query choroidal infarcts. We haven't done a FFA for this patient, but here they seem to be choroidal infarcts. And same goes for the left eye also, where we can see sheathing of the vessels, perivascular infiltrates, and infarcts. When we did OCT for this patient, here we can see a very good image which shows a very specific sign. Here we can see SRF, the IRF in the right eye, and this area, this is called bacillary layer detachment. Basically, this is the splitting of the photoreceptor layer. The splitting of the myoids on the inner segment of the photoreceptor layer. Now, when we were searching for literature, I went through this article, The Bacillary Detachment in Posterior Segment Ocular Disease, which was given by Maria et al. In the ophthalmology retina. Here they have given n number of diseases where we could see bacillary layer detachment. It is more commonly seen in VKH, toxoplasma retinochoroiditis, even in posterior scleritis, as we have seen a case today also in our clinic, where the patient presented with bacillary layer detachment and posterior scleritis. It could be seen in APM PPE. It could be seen in metastasis from lung and breast carcinomas. It could be seen in exudative AMD. When I was searching in the literature, there's only one case where it is reported bacillary layer detachment in SLE, but that was not SLE retinopathy. That was a SLE lupus patient with CSR. So this one thing we want to report, this BLD sign in lupus retinopathy. So this is the most important aspect of our case report, as we are trying to make it the important factor in case report, this sign of bacillary layer detachment in lupus retinopathy. In the other eye, we could see the SRF, the IRF, and the inner retinal hyperreflectivity, which is a sign of ischemia.
So are we done, Dr. Weber?
No, so I think there's an issue with his audio.
Okay.
I think we've lost him.
Yeah.
This usually happens when he loses network. So I think then the screen freezes where it is. So maybe the screen will drop out in a moment probably. Because let's see if he's there on. I think he's not on board. He'll have to join again. Yeah, see. So
Yeah.
he'll be joining.
Yeah. So in the meantime, can I request Dr. Shweta to please, kind of little bit tell us about this, just moderate the discussion for this case?
Yes, sir.
You join.
Yes, sir. So pediatric lupus is itself a very rare entity, and it has been seen that it is obviously more prevalent in females. And the thing is that there is one article that we read where lupus retinopathy, although in all of the criteria for diagnosis of lupus, ophthalmic criteria are not included at all. There are like ANA positivity is a must. Then there are criteria for anti-Smith and anti-DS DNA body positive. And then there are musculoskeletal and pleural effusion and skin features. and other features, nephrology features and pancytopenia, but ophthalm features are not used as a criteria at all in the diagnosis. Although there are some studies where lupus retinopathy, the response to treatment can be monitored by the regression of retinopathy. And those with lupus retinopathy, patients with lupus retinopathy have a higher incidence of lupus nephropathy, autoimmune hemolytic anemia, and neuropsychiatric disorders. And they do have a higher mortality rate. So this girl patient, she was referred to a pediatric rheumatologist. She had pancytopenia, although her renal parameters turned out to be normal, and she had skin manifestations also, a lot of skin papules and rash and all. And by the pediatric rheumatologist, she was she was given pulse IVMP therapy, and then she was put on hydroxychloroquine tablet. So that was the treatment that we had so far. And I think after that, she was being treated in PGI. And we have 3 visits with us where after the initiation of therapy, steroid therapy and HCQ, her swelling had come down, SRF had come down. But we're still trying to get back in touch with her to see what is her latest follow-up.
Right. Thanks, Dr. Yeah,
Am
and
I audible?
Weber has joined back, so he can continue just last few slides. I think you can just So we were
My
just
network just dropped. Yes, sir. My network just dropped, sir.
no problem. You can just show the follow up now after the treatment slide. Yeah, I said this is the investigation. Go ahead, please go ahead.
These are the photo follow-up visits. Not great images because the child was not that cooperative in her follow-up image. And this is the change analysis, the OCT, where we could see that the SRF and IRF is in both the eyes.
I think your screen has frozen, Weber. I mean, you're still at the investigation slide.
Yeah,
Okay.
now we can see. Yeah. Yes, so we can see good resolution of the changes, and this is a serial OCT change analysis of the right and the left eye.
Yes.
So I think the positive points about this case presentation is that there is decent, quite good documentation. It's a relatively rare condition, and it is well worked up as far as the systemic investigations are concerned. And we do have specialist rheumatology treatment which was given earlier at Gangaram, and then now she's being treated at PGI. Now we are just waiting somehow to get her final follow up. We are trying to make her follow up for the past couple of months. She has not turned up, so hopefully if we can get her to follow up one more time, then I think we'll have the final follow up picture and we can put this together. And I think this is quite decent to send for publication, because this is a very rare kind of condition that we have.
Yes.
So any other comments, Dr. Vaibhav, Dr. Shweta, Dr. Abhijat?
In this case report, so first I think we can highlight how rare pediatric lupus and lupus retinopathy is, and then apart from that, even make the bacillary layer detachment the highlight also of our report.
Sure, I think I agree with you.
Yes, sir.
So I think if we can get a follow up on this case and the first cilioretinal artery case, so I think they are fairly advanced in their stage of readiness for publication. And Irvan, we definitely need to work more before we can conclusively kind of say. So I think the first and the third project, Weber, I think you should work hard and try to kind of complete it so that we can proceed. You can write it so that a draft is there, and then Dr. Shweta will be helping, and I'll also oversee and supervise, and then we
Yes,
can just
sir.
work towards finalization for submission. Sure.
Yes. Yes. Yes.
Yes, sir.
Okay, thank you. And I think if there are any questions from other colleagues or any feedback.
No, I think all the cases look very interesting and worthy of publication. So we should definitely move them forward. In fact, in this vein, I'm happy that Weber has already chosen this potential, publication in which he plans to do it. And I think Dr. Amrita and Dr. Tulsi should also be looking at which publications as well. And, I mean, we are at a much earlier stage. You guys are already way ahead of us. So we need to work much harder and, push our team to kind of, move forward with this thing. And we look forward to Dr. Saurabh's guidance. He has, I think, the maximum experience amongst all of us for, in this area. So we'll look forward to that support.
Yeah, sure. Absolutely.
Thank you.
Okay.
And thanks everybody for a nice session today.
Thank you, everyone.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you,
Thank you,
sir.
sir.
Thanks. Bye.
Bye, sir.
Bye.